My name is Carlene and I'm a student in the BCIT Course NSPN 7155, the Breastfeeding Experience. This video is about breastfeeding challenges of hypoglycemia and decreased milk supply. In this video, I will discuss these challenges and use the situated clinical decision-making framework as a tool to understand these challenges and guide clinical decision-making. The situated clinical decision-making model involves 5 components: knowledge, cues, judgments, decisions, and evaluation of outcome. Let's begin with the knowledge component of this challenge. What defines hypoglycemia in a newborn? Hypoglycemia means that the body's demand for glucose is exceeding glucose delivery. Before the infant is born, they rely on their mother for glucose. During the last 4 to 8 weeks of pregnancy, glucose is stored in the infant's liver in the form of glycogen. The stress of birth and adapting to life outside the womb uses these stores of energy. Until the newborn can get adequate glucose from feedings, these glycogen stores are converted to glucose and used as energy. The most common cause of hypoglycemia in newborns is secretion of too much insulin. This most often occurs in infants of diabetic mothers. Maternal risk factors for hypoglycemia in newborns include mothers with diabetes in pregnancy or who are diabetic in general, certain drugs taken by mothers such as oral hypoglycemic agents and tocolytics, and also intrapartum administration of glucose. Neonatal risk factors for hypoglycemia include prematurity, postmaturity, intrauterine growth restriction, large or small for gestational age, asphyxia, cold stress, infection, hyperviscosity or polycythemia, erythroblastosis fetalis, congenital heart problems, and endocrine disorders. Now that we've discussed the issue of hypoglycemia, let's look at decreased milk supply. What is decreased milk supply? Decreased milk supply is when the amount of milk produced by the mother is not sufficient to meet the needs of her infant. Fortunately, instances where regardless of how much the mother tries to breastfeed, she cannot make enough milk are rare. That being said, there are factors that do contribute to decreased milk supply. Maternal factors that may contribute to decreased milk supply include primary insufficiency. This is when there's insufficient growth and development of the breast. Hormonal issues that can't be treated, such as Sheehan syndrome and polycystic ovarian syndrome. Hypothyroidism, retained placental products, certain medications, smoking, and breast surgery. Neonatal factors that may contribute to decreased milk supply include tongue tie, which can interfere with effective milk transfer, jaundice, thyroid problems, illness or infection, neurological disorders or congenital issues, and preterm infants or infants who are small for gestational age. Factors in the mother-infant dyad that contribute to decreased milk supply include infrequent feeds, ineffective feeds, and low milk removal or low milk intake. Now let's discuss cues that may be present with these challenges. With hypoglycemia, we need to observe for cues that may be an indication, but it's important to note that sometimes hypoglycemia may occur without obvious signs and symptoms. Signs in the newborn may be jitteriness, tremors, seizures, hypotonia, lethargy, episodes of acrocyanosis, intermittent apneic periods, tachypnea, weak or a high-pitched cry, diaphoresis, pallor, and temperature instability. Observe the mother-infant dyad when breastfeeding. Is there evidence of a good latch? Are swallows audible? Newborns who are considered at risk should be tested for hypoglycemia. A blood glucose level of less than 2 at 2 hours of age and less than 2.6 at subsequent checks are significant for hypoglycemia worthy of intervention. Listen to the mother and other family members for statements that may indicate there is a problem. Have they observed any of the signs or symptoms discussed? Observe the mother, babe, and their relationship for cues that may indicate a decreased milk supply. The first place to start is to assess breastfeeding. Assessing the infant for weight loss or gain within normal limits, as well as the appropriate number of wet diapers for age, will provide cues about the adequacy of feedings. Signs of infant feeding problems might include falling asleep after feeding for less than 5 minutes, refusal to breastfeed, tongue thrusting, smacking or clicking sounds, dimpling of the cheeks, failure to open the mouth wide at latch on, short, choppy motions of the jaw. A health history from the mother will also provide cues about potential feeding problems. After observing cues, judgments must be made about the situation at hand. When it comes to neonatal hypoglycemia, if babies are either at risk or are exhibiting signs and symptoms of hypoglycemia, blood glucose should be checked. A blood glucose level of less than 2 at 2 hours of birth or less than 2.6 at subsequent checks warrants further investigation. The Canadian Pediatric Society has developed an algorithm to support decision-making around the management of neonatal hypoglycemia. When it comes to mothers having decreased milk supply, all newborn babies should be monitored for adequate feedings based on the adequate output for age and weight gain or loss within normal limits. This is the most reliable indicator of adequate milk supply. When addressing these two breastfeeding challenges together, it is important to establish priorities. Nursing priorities for these challenges would include effective monitoring and treatment of hypoglycemia in the neonate, promoting milk supply as much as possible through early skin-to-skin contact, breastfeeding early and often, monitoring for an effective latch and breastfeeding exclusively if possible, and finally, monitoring infant output and weight gain to determine whether or not feedings are adequate. Making decisions is the next step once judgments have been formed. How will the hypoglycemia be managed? In the management of neonatal hypoglycemia, enteral feeding should be the first step. Ideally, this should be done at the breast. If breastfeeding is not effective, the infant can receive expressed breast milk or donor milk via a cup, spoon, or syringe. If breast milk is not available, a breast milk substitute may be used. If the infant does not respond to enteral feeding, an intravenous infusion of dextrose may be initiated. If IV dextrose is needed, breastfeeding should still be continued and supported. When it comes to low milk supply, assessing the 3 E's of breastfeeding is a good place to begin. Aim to have the infant feed within 1 hour of delivery. Ensure the infant feeds often, at least 8 times within a 24-hour period. Monitor the effectiveness of feeds by observing the latch and length of feeds. Encourage exclusive breastfeeding unless supplementation is medically indicated, as this will help increase milk supply. If the infant is not feeding well, mothers should be taught and encouraged to hand express their own breast milk, as well as pump if necessary. Mothers whose milk supply is truly low due to anatomical or physiological conditions may choose to use a supplemental nursing system, which allows the infant to suckle at the breast while receiving donor milk or formula through a small tube that carries milk to the nipple. When both the challenges of hypoglycemia and low milk supply occur together, hypoglycemia should still be treated as previously outlined if possible. If the milk supply is truly low, then feeding can be addressed as I just discussed. Even if IV dextrose is needed to manage hypoglycemia, suckling at the breast and skin-to-skin contact are beneficial for both mom and babe as they enhance the physiological stability of the infant, promote milk production, and decrease stress. For both of these breastfeeding challenges, consulting other professionals would be a good idea. For example, a lactation consultant could assist with feeding difficulties that may be contributing to hypoglycemia and low milk supply. When evaluating the outcomes of this situation, questions that we could ask include: has the hypoglycemia resolved? Is milk supply increasing? If the mother is breastfeeding, is the latch effective and are feedings adequate? Is the infant's output within normal limits? Is infant weight gain or loss within normal limits? In conclusion, the challenge of hypoglycemia in the newborn with decreased milk supply in the mother is a complex challenge. Many of the cues that may be evident in this situation have been presented. Priorities for care in this situation have been listed. Potential solutions to these problems have also been discussed, as well as questions that may be used to evaluate outcomes. I hope you have enjoyed examining the challenge of hypoglycemia in the neonate and decrease milk supply in the mother using the situated clinical decision-making framework. Thanks for watching.